It's great to see people from across the 4 provinces here. So I didn't like the topic standardized PD education, so I decided I would talk about a few other things in addition to that. I do have one investigator-initiated grant from Baxter through their extramural grant competition, and that's actually, we're looking at nationally at different strategies around home dialysis education, among other things. But we're not going to talk about that today because that's just ongoing. So I thought that we would talk just a little bit about the goals of, and throughout we're going to talk about PD education, but at the end we will talk very briefly about, I think that's probably, we don't just educate about PD, we need to be educating about all the treatment options. I'll talk very briefly about a systematic review that Rob has been doing around dialysis modality education, and then an overview of a randomized trial that we did. And as Rob says, we have lots of small single-center randomized trials, and that's suboptimal, but as his systematic review showed, it was the only randomized trial out there, so somewhat embarrassingly I will show that. And we'll talk about the specifics of that intervention, because it's people that were much smarter than me, who knew something about adult education and how to design an educational program, actually set up the program. So if the goal of PD education is to increase use of peritoneal dialysis, I guess first off, is that in fact an appropriate goal? I think from Daniel and the things you've heard today, and as Daniel said, you've all drunk the Kool-Aid. We all think that's a good thing to do. I won't go into the why, but if that's simply your goal, actually standardized PD education may not be necessarily the best way to do that. You could have a PD first program or force all patients to start on peritoneal dialysis. Obviously, our multidisciplinary CKD clinics, of which there's about 100 across the country, I mean, that was one of the reasons why they were set up, was to educate and prepare people for all the different treatment options that are available. We heard about programs targeting unplanned urgent starts. Rob tomorrow, through the DMAR project, will tell you about how you overcome barriers to use of peritoneal dialysis across the whole spectrum. And then lastly, what we're going to focus on today is really patient education, but as Daniel mentioned, it's important to educate providers as well. So I will talk very briefly about 2 things. So we could force all patients to start peritoneal dialysis, and actually that was tried. In Edmonton, they had capped out at 120 hemodialysis patients in 1992, and so they specifically actually had a policy whereby everybody had to start peritoneal dialysis, and 2 years later, their PD program had grown by 80 patients, and their in-center hemodialysis program was exactly the same number. So they looked at quality of life for people who started on peritoneal dialysis before that program change and after that program change. And to just summarize, quality of life was lower for the people who started peritoneal dialysis after that change in policy. As Daniel mentioned, actually we don't have any randomized trials, and I suspect if you did a randomized trial, you may not see any difference in quality of life across hemodialysis and peritoneal dialysis. But I know that if you take people who want to do peritoneal dialysis and you force them to do hemodialysis, they're probably likely to, if it's not working out for their lifestyle, they're likely to have lower quality of life, and vice versa as well. And I guess the one message I'd like you to take home at the end of the day is, I think if you could address barriers to use of peritoneal dialysis, and you simply really educate the patient, and you have a provider that is willing to support them, whatever their choice is, actually most patients will choose home dialysis as long as there's not an absolute reason why they're unable to do it. And again, I'm not going to talk about multidisciplinary programs at all, but again, when they were started up, Adira and others had looked at the programs, and again, they were associated with higher use of home dialysis. But we will focus just on education. And the one thing I've learned from the adult educators that we've worked with over the years is that we often, when we design an educational program, we think we need to tell patients everything. Here's what's going to happen on day 1 of, you're going for your transplant assessment. Here's what's going to happen the night before your transplant. here's what's going to happen on day one. There's a 30% risk that you might get rejection, and at a year there's a 90% chance it's going to be successful. Actually, that's not what those just in and out of patients' heads. What we really need to focus on is what's these different therapies going to look like for you, and what's the advantages and the disadvantages. We can teach you how to do it later. We can tell you closer to the transplant what things are going to look like for that 3-month period, or what it's going to look like that whole training week of peritoneal dialysis. But when you're educating patients about the different types of dialysis, you should just be focusing on the choice, the advantages and disadvantages. You do need to have some understanding of what are the barriers to somebody getting on peritoneal dialysis locally. Is it that nobody actually has heard of peritoneal dialysis before? Or are there other, are they frightened that they've heard actually that everybody on peritoneal dialysis gets infections, which actually in some centers is true. Patients think they're more likely to get infections in their belly, and that would be worse. And then the education needs to be designed with the adult learner in mind. And I certainly do not learn like I did when I was 17. Actually, I don't learn much anymore at all. But adults learn differently than students. So actually, before we designed this educational program that we tested in this study, actually Kevin McLaughlin had interviewed and surveyed providers, nurses, and physicians. He had surveyed people in the kidney care clinics, and he had also surveyed a bunch of people on in-center hemodialysis and just asked about their barriers. And apparently this, if you know anything about psychology, apparently you typically lump them into knowledge, attitudes, and skills. So in the knowledge area, in fact, most of our patients, about 90% of them knew that there was such a thing as home dialysis, but 60% of them had no explanation of what peritoneal dialysis was. 36% had a significant lack of understanding. Around the skills, the interesting thing is a lot of people this was not just about peritoneal dialysis, it was about home dialysis, but a lot of people, and I've just highlighted in red, had a needle phobia and felt there was a lack of space at home, so they wouldn't be able to do those types of things because of these barriers. So an education program has to address those types of things. And then from an attitudes perspective, which is actually what's really hard to change in all of us, but in particular in adults, is getting people, if you're going to change behaviors, you have to change people's attitudes. So there was a feeling out there that patients shouldn't be unsupervised. Some people felt they couldn't be trained, they couldn't learn these skills. There was a lack of motivation, there was a fear of change, fear of substandard care, fear of social isolation. So you have to address all these things in your educational intervention or it's not going to be successful. But before we get onto the intervention, this systematic review that Rob looked at is actually if the goal of education is to increase use of PD, does it actually do that? So they identified observational studies and randomized trials to look at the association between receiving education and either making a choice that they want to do PD or actually receiving PD. And this forest plot, so the solid line, if the study didn't have any impact on the likelihood of receiving peritoneal dialysis, the diamond would be across that solid vertical line, but it's significantly to the right of that. So the odds ratio, or the odds of receiving peritoneal dialysis if you received education, was about 3.5. These were all observational studies. What about simply a patient saying at the end of the study, I want to do peritoneal dialysis? Again, there were some observational studies and there was one randomized trial that looked at this, and the odds ratio in the randomized trial that we presented was about 4.5. And again, the odds ratio of choosing peritoneal dialysis was higher with education. So does it increase use of PD if that's our goal? Well, probably. Certainly there's a moderate association between getting educated and the likelihood of choosing it, and then going on to receive it. And we'll talk a little bit about that. Like if a person chooses it, how likely are they actually then to go on to receive it? The one slide on this issue of standardized, I don't know, well, certainly we should not be recreating the wheel. And the one thing I've learned from engaging with all these CKD clinics across the country is we all do things differently, and we all develop our own policies, and we all develop our own educational programs. And I've lost favor with that strategy. I just think we're recreating the wheel, and we're all doing a lot of the same thing. And actually, there's some fantastic resources. In the Thunder Bay, multidisciplinary clinic was actually one of the only, had some unique educational resources. Toronto's got some interesting ones. We, have a video, but we need to actually pull all these resources together. BC Renal's got a lot of good resources. So we don't need to recreate the wheel, but I do think there needs to be some, way to take into account local barriers when you're designing your educational program. I think you need to have some understanding of why people don't go on home dialysis. So this randomized trial that we did was published almost 10 years ago now, and it builds on that work on the barriers. So out of that work on the barriers, Kevin McLaughlin and others designed a specific intervention aimed at adults with stage 4 and stage 5 chronic kidney disease. And the outcome was their choice at the end of the study of what type of dialysis they wanted to do. Everybody was managed in the multidisciplinary CKD clinic, so they'd all received education about dialysis modalities already, and they had their one-on-one clinic visits with their nurse and the physician, and that was emphasized. So everybody in the study received that. If you didn't speak English, if you had dementia, if you weren't personally independent, in fact, if you were on dialysis, now we do obviously, just like a lot of other programs, we have a Janice, our educator who goes around and educates those people who end up in hospital acutely on dialysis. This study excluded those people, though. This is all people who are outpatients. And what the educators told us is that you need to prime people with a bit of information first. So everybody that came into the study who was randomized to get the education, they received a pamphlet entitled Choosing the Type of Dialysis Best Suited to You. And it just briefly described the different types of dialysis, and it talked about the potential advantages and disadvantages of home dialysis. Talked about diet, travel, flexibility, talked about supervision. And then there was a manual that described PD in more detail and home hemo in more detail, and we had a video that we actually, it was testimonials from patients on the different modalities, much like the testimonial that BC Renal has for PD, and it was based on that understanding of what the local barriers were. They were mailed that a couple of weeks in advance. That's what so there wasn't a lot of information provided in these pamphlets. About 2 weeks later, we held a 90-minute small group session with 3 to 6 patients, and each one of them was invited to bring a family member, and most of them did. And then our pre-dialysis modality educator nurse facilitated that. And essentially, at the very beginning, what we found is that about 40% of people hadn't opened their educational materials at all, and they hadn't watched the video. So we showed a little snippet of the video at the very start, just so they understood what peritoneal dialysis looked like, and what home hemodialysis looked like. We just showed those. It was about 7 minutes total. And then we had 5 slides on a PowerPoint, and this was essentially what the slide looked like. So it talked about dialysis, and then it blew up the hemodialysis, et cetera. And it just talked about the different dialysis options. And then we actually had patients brainstorm about the advantages and disadvantages. So they just watched the video. We had just showed the different options, and then we asked them to talk about the advantages and disadvantages of each of the dialysis modalities, and the patients had to come up with these. At the end, obviously, the nurse had a list, and if there was, sometimes, in fact, they said, peritoneal dialysis, that's a higher risk of infection. So at the end, we would carefully, correct the things that probably weren't true, or we would say there's also a risk of infection on hemodialysis. And we would add on any that hadn't been identified. And then we broke them into small groups. And each of them was given a case scenario. There was just a very brief paragraph. It said, this is a 67-year-old woman who lives an hour south of Calgary, and she has a granddaughter that she looks after during the week, and she's looking at needing to start dialysis. What would the best type of dialysis option be for this person? And then they came back to the larger group, and they presented it back to the larger group, and then at the end, there was questions, and then they were sent home with homework to discuss their situation with their own family and think about their decision. As I said, everybody received care through the multidisciplinary clinic. Patients were relatively well balanced at baseline. GFR was around 20. About 34 of the 35 patients in standard of care filled out the final questionnaire around choice, and 28, we lost one to death, one started peritoneal dialysis, one was transplanted, and a few didn't return their questionnaires. And the top row is at baseline. About 50% of people in both groups said they wanted to do home dialysis. Simply receiving the educational booklets didn't really change people's mind, but by the end of the study, about 80% of people in the intervention group said they wanted to do home dialysis, and about 50 people the same. There was no change in the standard care group. So where was this change occurring? Well, actually, it was occurring in people who at the start said they didn't know what they wanted to do, or they wanted to do in-center dialysis. And if you looked at those people in the two groups, by the end of the study in the standard care group, 16%, so some people just naturally migrated towards thinking they wanted to do home dialysis. But in the intervention group, about 64% of those patients had identified they wanted to do home dialysis. Again, so if we simply educate people, often they're going to choose home dialysis. But who cares what they'll say they'll do? What happens to them? So we followed these people for about 3 years, and about 22 of them ended up starting dialysis. 20 of them actually started dialysis and didn't die immediately. And at 90 days, in the control group, about half of them were on home dialysis, and in the intervention group, about 87% were on home dialysis. But actually, maybe more importantly, did they do what they said they would do? So at the bottom there, of the 8 who said they were going to, regardless of whether they'd received education or not, if they said they were going to do in-center dialysis, 7 of them were on in-center dialysis. 12 that said they intended to do home dialysis, 11 of them were on home dialysis. So it seemed like a reasonable proxy. So just to back up again, I think the notion that we educate people for PD is probably naive. And as Janice said, we're looking at implementing across Alberta more of a standardized education package for all of the treatment options. And so actually the goal is to actually increase patient knowledge and informed decision making given that patient's circumstances. And then where appropriate and consistent with the patient's wishes, education will promote living transplantation, home dialysis, and non-dialysis supportive care. So I'll stop there, just simply say that most patients, as we know, the default is in-center hemodialysis. There are barriers to home dialysis, but if we simply educate patients, the vast majority of people with progressive chronic kidney disease will actually choose home dialysis. There's some great resources on the BC Renal website, as Dr. Dasgupta mentioned. There's also some education tools that are available on the CanNet website. There's a whiteboard, there's a video, that video we mentioned about selecting the optimal dialysis modality. There's a decision aid about home dialysis. But I think, again, if all we do is send patients out these things, that's probably not enough. We need to have more of an interaction with them and facilitate their learning. And I'll stop there.